See, I had this patient of displaced bilateral non-union high tibal osteotomy, 57-year-old housewife, weighing 71 kg, 5 feet 1 inch height, underwent bilateral stage dome HTO 3 years back before she came to me. Patient walking with a walker with bilateral continuous pain. This is the X-ray on the left side. You can note there is offsetting of the distal part of the tibia backwards, which gives little room for placing any shortest, narrowest base plate. There is offsetting here on the lateral side, so it has all the issues with badly displaced high tibial osteotomy plus the non-union. And here is the X-ray on the right side, same sort of an issue. It was an attempted dome HTO by the surgeon, together with known problems of ATO conversion. Like TT avulsion, we have to be very careful when you dissect that area. Extension mechanism, the whole patellar tendon might just avulse off. It had a patella infra. How do we create a base plate holder of tibial base plate surface? Specific challenges were offset stem for AP and lateral displacement. You can see hardly there is an overlap which you can depend on. And at that point of time, we never had this offset stem. Distal part was protruding posterior, and any dissection in that area would incur the vascular handling. We did a stress fuse. It was partially correctable. So this is what we had to handle. And this is what on the... You can note that we are using template, and this gives us unique advantage of tracking down the medulla and where to make an insertion, because standard anatomical landmarks were missing. So what we did, this is the offset that I was talking about. There is no bone where you can place your metallic part on, and this is what we have drawn with the template to know exactly how the tibia is going to track down. And this is the plan. You can see what I was saying all the time. There is offsetting in both planes. The posterior offsetting is something which is not much reported in the literature at all. There is a pushing of vessel possibly. And in that small medial area, you have to fix a graft which will take load of tibial base plate. And this is what we planned. There was no other fixation modality but K-wire to fix it up, because hardly you could keep a screwdriver in that plane to get the fixation done. So we did, you can see that. This is the bone graft that you can see on the posterior side, created. How do we negotiate a reamer? Because the whole direction was so haywire. So we took intra-op X-ray to find out what is the entry point for the reamer. And no attempt was done to reduce non-union in the AP plane. We located the entry of stem extender by intra-op radiography. We undersized tibia, the smallest that we could have, and we were all the time aware of neurovascular bundle as there was a posterior displacement. So this is the template guidance for what way the post-op base plate placing will be. And this is what we did. Carefully dissected out posteriorly, put a K-wire across. This is the graph that went there. We negotiated it to create a wider tibial surface to place the tibial component. With a long stem here, and this is what we are having. This is the K-wire that has been pushed through the cement, and that's a lateral X-ray. This is 10-year follow-up. So this is presented because of sheer difficulty of negotiating a tibial base plate, which is offsetted posteriorly where the vasculars are there, and creating a graft bed for a smallest possible size of tibial base plate.
Great case. That's amazing. Dr. Bende, would you reduce that? Would you attempt to take down that non-union and reduce it and then go through the same steps, or leave it as is because it's so difficult to mobilize that proximal piece?
The HTO is so close to the articular surface that if I try to dissociate the fibrous non-union which is there and then take a cut on the top of that, then I will have nothing left in my hand. it'll end up requiring a tumor prosthesis there. So I wouldn't like to, dissociate, try to reduce it because there are too many soft tissues around and too many nerves and muscles to, vessels.
Yeah, Harish, I think you have a point, the same point we were trying to prove.
I'll just accept and do
Any attempt, sorry.
Go ahead, yeah, so he's agreeing
Any
with you,
attempt to move the tibial tubercle would be disaster because God knows where it will hang and where it will be fixed back to.
Yeah.
We have to totally recreate by this posterior graft and make sure now the new entry is in alignment with tibia in such a way that it is overlapping on none of the margins.
Did you do anything to graft the non-union side other than the posterior graft that you put on, or did you just accept that compression and fixation would be sufficient to get it to heal?
Well, I think we researched all around, and what we found is overlapping between the two dias of tibia were hardly leaving any place for putting a base plate.
You basically just
Yes.
shish kebabbed it and let the compression help it heal.
Correct.
Maybe the reaming kind of stirs it up a little bit, maybe that's what does, okay. Yeah, comment, yeah. Dr. Marathi?
Just the K-wire is usually tendency to migrate it after some time.
I had to dissect the whole popliteal bundle to get an area to put a plate there, which I was not very convinced about. I agree K-wire is a sore thing to have a look at K-wire, but that is the only best thing I could, which I engaged through the cement, through the bone. So it's all improvisation, Everything about it is
Yeah.
challenge.
One thing in these cases are very important. Take all femoral cut first so you get the space and try to reduce whatever is possible. Then always take intramedullary tibial cut, unlike extramedullary devices. Put an intramedullary rod, take a tibial cut. So I will do intramedullary tibial cut. That is most important in these type of cases.
So it's aligned off the diaphysis, yeah.
I think one more difficulty was getting the upper end tibia anteriorly dislocated in front of femur and make a tibial cut. That was the toughest challenge because it is already gone beyond its limit posteriorly.
And the lateral, you talked about using an offset stem, but it doesn't look like, this looks like a straight stem here you're showing, is that correct?
Yeah.
Yeah. Would offset have allowed you to anteriorize? You mentioned that in your planning.
I would say at that point of time, that sort of offset stem in a smaller size was not there.
Okay.
And it's multi-direction.
Yeah.
You have to get it back and laterally.
Yeah.
That was impossible.
And most of the offset stems start so much below the joint line that it doesn't really help you very much.
Okay. Extensor mechanism in the end was okay?
Yeah.
No lag?
We
or
could,
anything like that?
whatever best we can. I mean,
Yeah.
it won't be ideal.
Right. A lot
There
better
are so
when you
many
started with.
compromises that,
Yeah. No, it looks great with great follow-up, long-term follow-up, right? Okay, fantastic. Thank you.